Hello and welcome. I'm Catherine Banwell, your host for today's program. Today, we're going to explore the goals of DLBCL treatment and discuss how you can play an active role in making care decisions. Before we get into the discussion, please remember that this program is not a substitute for seeking medical advice. Please refer to your healthcare team about what might be best for you. Well, joining us today is Dr. Jason Westin. Dr. Westin, welcome. Would you please introduce yourself?
Of course. Happy to be here. Thank you for inviting me. My name is Jason Westin. I'm the Director of Lymphoma Clinical Research and the Section Chief for Aggressive Lymphomas at MD Anderson Cancer Center in Houston, Texas.
Excellent. Thank you so much for taking time to join us today. Today, we're going to be learning about DLBCL treatment goals and how patients can be active members of their team. So let's start by understanding who is typically on a patient's DLBCL healthcare team.
It's a good question. The members of the DLBCL healthcare team usually consist of a physician, and this person usually would start the process of saying, this is something I don't know what's going on with this mass or this pain you're having. Let's get some imaging. Let's get a biopsy to figure out what's going on. There'd often be a nurse as a member of the team, and the nurse usually provides a critical service in terms of help facilitating patients to understand what's going on and to work with the healthcare team directly to provide excellent patient care. And eventually there would often be a pharmacist involved in terms of the chemotherapy or treatments that are administered to help review those and work with the physician and the nurse directly. Those would be the main members of the healthcare team. Occasionally there might be a social worker or there might be other care providers that are involved, but usually it's the physician, the nurse, and then sometimes a physician extender, such as a PA or a nurse practitioner.
Okay. What do you feel is the patient's role as a team member?
Patients are a critical part of our team and are often the decider of what goes on. The physicians, nurses, PAs, pharmacists, our jobs are to help educate the patient and to help the patient to decide what the best treatment is. Ultimately, it's the patient's responsibility to understand what's going on, to ask good questions, and then to make a decision about what treatments are best for them.
Mm-hmm. What role do caregivers take?
Caregivers often play a very important role, and it's variable from person to person how involved a caregiver is. But if patients have symptoms or side effects of treatment, caregivers are often critical to make sure patients get the appropriate medical care that they need. Some treatments may have more potential for side effects than others, and sometimes caregivers are essential to actually stay with a patient even during an admission to the hospital to make sure that patients are monitored closely. And we may talk about different treatments today during the interview, but at our center, sometimes we even mandate that the caregiver is involved in the sense of staying with the patient in the hospital for certain therapy types. But in general, being a supportive family member or caregiver, it's a good thing to have, even if we don't have a lot of toxicities for emotional and physical support. But sometimes it's really important to help manage toxicities.
Right. Before we move on to discuss the types of treatment, what are the goals of DLBCL treatment and how do they vary by patient?
It's a very important question to define at the outset. What are we trying to accomplish when we're talking about different treatments that we could recommend? DLBCL is a curable disease, and unfortunately, we don't cure as many patients as we'd like. The majority of patients are cured, but we always want to try and do better. But at the outset, we define our goals. And if somebody's newly diagnosed, the goal of treatments is to try and go for a cure. That's kind of the end of that sentence when I'm talking to my patient, that we're going for cure, period. And then we describe how we get there. If somebody has relapsed or refractory disease, if the first treatments don't work, usually we're still trying to go for cure, but there are some contexts where curative treatment may be too toxic. The treatment itself may be a bad idea just because of the potential for toxicities to be too much for a patient to tolerate. So there are situations, if the patient's had a cancer that's not gone away with the standard approach, sometimes we're still going for cure. Sometimes that may be difficult to achieve, and we'd be going for a palliative treatment to try and prolong the patient's quality of life and to try and give the patient more good days without harming them with treatments. But by and large, when we're talking about the category of large B-cell lymphoma, the intention of treatment is to go for a cure.
Mm-hmm. How can patients make sure they understand their goals of treatment?
I think it's important to ask physicians and PAs and nurses at the outset about the goals of treatment. Sometimes we kind of move quickly from diagnosis to treatment and don't necessarily take a moment to talk about what are we trying to accomplish with this treatment. We see a fire and we're trying to put it out. and the patient's excited to get started after getting the scare of a diagnosis. But I do think clarifying, can we talk a little bit about what the goal of this treatment is? Because sometimes there can be a mismatch between what a patient might expect the goal is and a physician or a PA or a nurse might expect the goal is. And if we're not clarifying that and on the same page about that, sometimes there could be conflicts or confusion as we go into the treatments.
Mm-hmm. All right. I think we have a good understanding of treatment goals. So when is it time to treat DLBCL?
DLBCL is not a cancer that we wait to treat. This is a cancer that needs treatment very quickly after diagnosis. If a patient were not treated, the cancer would progress fairly rapidly. Some DLBCLs progress faster than others, but we would expect that if treatments were not administered, if we lived a century ago when treatments didn't really exist, people would live at the most a few months with this cancer. This is a rapidly growing cancer that would result in death if we didn't take care of it. So the time to initiate treatment is basically after a biopsy is obtained, the pathologist says this is large B-cell lymphoma, a meeting with an oncologist occurs that says we've got to start a treatment, and then ASAP after that to get going. What we know from DLBCL patients in the past is those that require treatment sooner, meaning you get a biopsy on a Monday and by Friday night you're sick and you need treatment now or else, that tends to go along with a more aggressive version of DLBCL and perhaps can be associated with worse outcomes. Patients who get a biopsy and 4 weeks later, then they're in the oncologist's office talking about maybe we should start a treatment, but no symptoms, no problems. That usually goes along with a better prognosis. The so-called diagnosis to treatment interval can be actually powerfully prognostic.
Mm. So once it's time to treat, then of course, it's time to think about treatment options. So let's walk through the types of therapy that are used today in DLBCL treatment. First of all, let's talk about chemotherapy.
Yeah, so unfortunately, chemotherapy is still the coin of the realm when it comes to DLBCL therapy, especially in the frontline setting. So if a patient is newly diagnosed, no prior history of DLBCL, biopsy comes back and describes that's what we're looking at. The standard treatment, which has been around for about 40 plus years, is a combination of chemotherapy called CHOP, C-H-O-P, each letter representing a different medication. The antibody or immunotherapy Rituxan or rituximab was added about 20 years ago. And so the standard treatment for the past 20 years has been R-CHOP. And this has been tried and true. It's been tested many, many times to try and improve upon this or to beat this. And R-CHOP has been less toxic than other alternatives or as good as other alternatives through many, many, many trials. Now, late last year in 2021, there was finally a randomized phase 3 trial that showed an addition of a targeted therapy in place of one of the chemotherapy drugs had a slightly better progression-free survival at 2 years. The targeted therapy here is a drug called polatuzumab. Polatuzumab is an FDA-approved therapy for large B-cell lymphoma patients in the US. Currently, as of the time we're taping this, it's approved for patients with relapse disease. It's not yet approved based on this phase 3 trial, but that may change in the coming months. The improvement was modest, around 6% of patients different in terms of those who had progressed versus those who had not progressed at 2 years. So not an earthquake, but R-CHOP or variations of R-CHOP are still the standard treatment for patients outside of a clinical trial with newly diagnosed diffuse large B-cell lymphoma.
And what about CAR T-cell therapy?
The other treatment classes, the targeted therapies, including CAR T-cell or other antibodies, antibody drug conjugates, immunotherapies, bispecifics, there is a lot going on in new drugs and new drug development for DLBCL. As of today, most of those therapies that are approved are looked at in patients that have already had a frontline chemotherapy approach and the cancers come back. So those are approved, but they're either approved for patients in second line therapy after having had one line, cancer comes back, now we're in second line, or in third line therapy, 2 previous treatments, now we're in third line treatment. There's a lot of clinical trials, and I think we'll talk maybe about clinical trials in a bit, that are exploring use of these targeted therapies, including CAR T cells, including bispecific antibodies, including other targeted therapies as a potential for a frontline treatment. But outside of a clinical trial, R-CHOP or versions of R-CHOP are still the standard today.
Mm-hmm. And what about stem cell transplant?
Stem cell transplant's been a second-line therapy option, and it's been the standard second-line therapy for about 25 years. We'll see this change in the coming years. There have recently been 3 randomized clinical trials comparing stem cell transplant versus CAR T-cell. All 3 of those reported out some information in late 2021, with 2 of them having final results, 1 of them having an interim report. And one of the interim reports showed a significant improvement in chance of staying in remission and all the outcomes that were measured for CAR T-cell beating stem cell transplant. So we're waiting to see how the health authorities view these clinical trials. If CAR T-cell potentially moves into second-line treatment for a majority of patients instead of stem cell transplant. So stem cell transplant's been there, it's tried and true, it has cured a significant portion of patients. However, CAR T-cells potentially are better and may be moving into second line within the next year.
Okay, good to know. You touched upon clinical trials. Where do they fit in?
Yeah, in my view, clinical trials are our best weapon against cancer, period. I think that's true across the board, even for cancers like DLBCL, where the majority of patients are cured with a first treatment like an R-CHOP type therapy. All of our treatments at some level came from a clinical trial. We didn't just have treatments fall out of the cancer treatment tree. They all came from patients going on to clinical trials, trying to improve upon previous standards. And as I mentioned, CHOP has been there for about 40 years. R-CHOP has been there for about 20 years. We don't do a lot of things that we would consider, risk of death that we trust a 40-year-old technology to try and save us from. We like the latest, we like the modern, we like what's the shiny new object. And so clinical trials are the way that we define new standards and move forward to do new therapies. CAR T cells are an incredible advance. Those didn't exist a handful of years ago. They were only defined as successful in clinical trials. So my advice to a patient who's diagnosed with DLBCL is ask your provider, ask your physician or your PA or your nurse practitioner, what clinical trials are available to me? If the answer is we don't have any, go on the internet, figure out where you could go for a second opinion where clinical trials might be available. And there's plenty of resources online to try and figure this out. Time is of the essence for this disease. We don't have 6 months to shop around and go figure out what centers, but clinical trials are really the only engine we have to drive progress, to do better and cure more patients.
Yeah. You touched upon this earlier, Dr. Westin, but are there emerging DLBCL approaches that patients should know about?
Yes, there are thankfully many. We could spend several hours talking about lots of new therapies coming along. So it's a great answer to have. It's a wealth of an embarrassment of riches that we have for lots and lots of new therapies that appear quite promising in the early development stage. In terms of those that have actually crossed over the finish line to be approved by the FDA, we have a handful of new therapies in the past few years that have been approved. Previously, we didn't really have very many, but now there are multiple therapies that are approved by the FDA outside of a clinical trial that are targeted treatments. And those include antibody drug conjugates, basically an antibody like you make against an infection. However, this antibody has a chemotherapy warhead attached to the back of it. So effectively, it's a heat-seeking missile that finds whatever target we want it to find, in this case, cancer cells, and delivers a high-dose chemotherapy right to the bad guys, not to the good guys. There are also other immune therapies that we've seen that can be very powerful, antibodies plus immunomodulatory drugs, and we can talk about specific names of these if we'd like. And then lastly, there are other oral agents that are coming along that look very promising in terms of their ability to target the cancer cells more directly than growing cells. Lastly, there's a very new class of therapies, not yet approved, but very promising. And I mentioned this before, something called a bispecific antibody. Bispecific, we know the word bicycle in 2 wheels. Bispecific is 2 specific antibodies. Basically, it's an antibody that's grabbing onto a cancer cell and grabbing onto an immune cell and says, I'd like to introduce you guys. Why don't you guys come in proximity and see if we can have a party? And it's an idea here of trying to get the cancer cell to be attacked by the immune cell simply through this close proximity that occurs. Not yet approved, looks very promising, and I think probably will be approved for multiple different lymphoma types, including large B cell in the coming years.
Okay, that's really good information. Related to clinical trials and research, we received a patient question before the program. Anthony wants to know, if I participate in a clinical trial, will I receive a placebo?
Great question, Anthony. I get this question all the time. The short answer is no. In the way that you're meaning this question, is there a possibility that you won't get an active treatment for your cancer? No, that's unethical. That's not something that would ever be done in a clinical trial when there's a clear indication that treatment is needed. The only time a placebo might be used is to try and check to see is something effective more than what we've done in the past. An example being, if we wanted to check a new drug in combination with R-CHOP, comparing it to R-CHOP alone, sometimes patients might get R-CHOP with the new drug or R-CHOP with a placebo, not a placebo by itself, but basically as a balance so that everybody's taking an extra pill on top of their regular therapy, because the placebo effect is powerful. Patients who take the new therapy, you've got the new pill, I feel better because I'm doing this new targeted treatment. And in reality, placebos do that too. So it does help to have a balance in terms of symptoms, in terms of effectiveness and adverse events, to have placebo-controlled trials. However, patients don't get only a placebo, they get standard treatment plus a placebo. So the only context I can think of you do that would be in that situation, or if we think you're already potentially cured, but we're giving an extra therapy just to be double sure versus observing the current standard, you may get a placebo there. But if you have active lymphoma that needs treatment, you will never get a placebo as your single therapy. That would be unethical and unacceptable. That does not happen.
Okay, that's really good to know. Thank you. Now that we have a better understanding of the types of treatment, let's talk about what goes into deciding on an approach. Since no two patients are exactly the same, I imagine then that their treatment approaches are different. So what do you consider when determining the best treatment option for an individual patient?
It's a very important question. How can we personalize treatments in a way that gets us down to what a single patient needs, not kind of bulk populations of thousands of patients, but the person sitting across the exam room?
Right.
For first-line DLBCL, someone who's newly diagnosed, unfortunately, the one-size-fit-all of R-CHOP being the standard, or versions of R-CHOP, the new treatment that I mentioned having a slight improvement, not yet approved by the FDA, there's not as much customization or personalization outside of clinical trials as I would like. We'd love to be smarter and to be able to say, well, you have the subtype A of large B cell, therefore you should get subtype therapy A, or subtype B and you get subtype therapy B. We have more of a one-size-fit-all approach in a frontline treatment outside of clinical trials. On clinical trials, sometimes patients will have a subtype of large B cell. We talk about things called the cell of origin. We talk about things called double hit. There are specific subtypes of DLBCL that occasionally a clinical trial will target that subtype and have a therapy that's supposed to work better in that subtype. So that's another reason to consider clinical trials, is the ability to potentially customize or personalize your therapy to go more specifically after what's wrong with your cancer cells, as opposed to having something that's kind of given as a shotgun approach to everyone. And the reason that R-CHOP is around for this long is that it works fairly well across the board in different subtypes. It's not something that's completely effective in one and completely ineffective in another. But in terms of personalizing therapies, clinical trials are an important thing to be considered. In the relapse space, with patients that have relapse disease, there we have more potential to customize treatments. And often that's done based upon characteristics of the tumor or the patient's preferences in terms of frequency of treatments, in terms of potential for side effects. There's more that can be done if somebody's already had a treatment and it came back. But clinical trials are a great way to try and customize or to drill down in terms of specifics about your particular cancer.
Mm-hmm. Can you touch upon treatment side effects?
Yes, treatment side effects obviously are very important to our patients in terms of what does their quality of life look like while ongoing therapy, while therapy is ongoing to try and get rid of this dread cancer. The side effects really depend upon what treatment we're talking about. And if we focus on frontline treatments, the initial treatments being R-CHOP-based treatments, side effects are chemotherapy side effects. And that includes low blood counts, white blood cells, red blood cells, platelets, risk of infection, along with the low white blood cells, and risk of fevers, prompting a trip to the emergency department for an evaluation. Thankfully, that's rare. Maybe 1 out of 4, 1 out of 5 patients would have an infection during treatments. But if it happens, it can be serious. Fatigue, nausea, which is usually very well controlled with medications, but nonetheless has to be something we watch out for. And for many patients, it's important to note that hair loss can occur from the chemotherapy. And that's something that it's easy to say, oh, I don't care about that. But for many people, when you look in the mirror and you see somebody else looking back at you, somebody that has a different physical appearance than you're used to, it can be quite distressing. That's unfortunately part of many patients' journey with the therapy for diffuse large B-cell lymphoma. In non-chemotherapy treatments, the targeted ones that I mentioned, either the antibody drug conjugates, the targeted immune therapies, or in CAR T cells, side effects can be very different, sometimes much less in terms of the side effects, other times completely different types of side effects. So it really matters what type of treatment you're talking about. And this is something you really want to clarify with your physician, with the nurse, with the PA. Tell me a lot of details about what I should expect when I'm feeling this, and give me reading material so I can digest it, think about it, and figure out what questions I need to ask after we first discuss this. But side effects really are an important part of the patient's journey.
Yeah. We had another audience question prior to the program. Where can I find a specialist?
It's a very important question. It depends where you live. So specialists are not on every oncology shop in the country. No. Lymphomas are not the most rare cancer. They're somewhere in the 7, 8, 9 range every year in terms of annual incidence of cancers, but that's lymphomas in general. Large B-cell lymphoma is the most common lymphoma, but it represents about 30,000 new diagnoses each year. 30,000 Americans are diagnosed with this disease each year. 30,000 sounds like a large number if you're thinking about a sporting event, but if you're thinking about compared to the entire US population, that's a relatively small number. Yeah. So I think that going to a relatively large cancer center, if that's something that's feasible for you, if you live within a driving distance or have the economic means to be seen at a cancer center, you're very likely to find a physician that has expertise in DLBCL. I practice at MD Anderson, where basically most of my patients have DLBCL, and I work in a department where all patients have have lymphoma of various subtypes. So I have a somewhat unique position where we're able to drill down about subtypes of subtypes of subtypes and kind of get into the weeds. Many physicians are able to keep up with the latest information for DLBCL, but may not be able to have that level of focus. I think that it's important to consider where you're being treated as something that's critical. And as mentioned before, asking about clinical trials. And if the place you're at doesn't have them or doesn't want to talk about them, maybe I should think about getting a second opinion someplace that might.
Yeah. It sounds like there are several factors to weigh when making this decision about treatment. And, lately we've been hearing this term shared decision-making, which basically means the patients and clinicians collaborate to make healthcare decisions. And it can help patients take a more active role in their care. So I'd like to get your thoughts on how best to make this process work. Are there questions that patients should consider asking about their proposed treatment plan?
Definitely. And I think shared decision-making is something that we view to be critical. We want everybody on board to feel like they've got some sense of ownership of these decisions and that they're involved in a way that's meaningful. At the end of the day, the patients make the decisions about which treatments are right for them, but they're trusting their healthcare team to give them good advice. This is not something that patients have expertise in. This is often out of nowhere that somebody is newly diagnosed and this was, not on their radar, not something that they ever thought that they'd be sitting in the chair talking about which type of therapy for this cancer. And so patients are often relying on the healthcare team to give them good advice. But it's a fair question, and it's I think one that's appropriate to ask of what are other treatment options? Are there other treatment options that we should be talking about? Basically exploring, is this the option you're presenting the option, or is this what you consider to be the best option? Oftentimes physicians and PAs and nurse practitioners might filter information such that, yeah, there are other options, but here's why they're bad. Here's why they're not right for you. But feeling that you've got some clarity about why a treatment choice was made, I think is often quite important. For first-line DLBCL, there's less options to consider, but in the relapse space, there are lots of options, and those should be discussed. And sometimes a healthcare provider, a physician might have their favorite, that they've had good experience with treatment A, and therefore they recommend treatment A to the next patient. But that may not always be the right treatment for a given patient. There may be reasons to consider other treatments. And so asking that question, what else is out there? What other treatments are there? Anything else that we should be considering, I think is a fair question to ask, an important one. And if the answer is nope, there aren't other treatment options, this is the one that we should choose, at least you're aware of that by asking that question. So I think that's an important one to clarify.
Right. And that leads me to my next question. What advice do you have for patients who don't feel comfortable speaking up but they have questions about their treatment plan?
Yeah, I think written questions sometimes are easier than trying to remember all of your questions. And it always is a bit problematic when I go into a visit and a patient has 6 pages of paper written down for questions. We unfortunately don't have unlimited time to get through all of those.
Right.
But trying to condense into sort of like prioritizing which of the questions are the ones that I feel like I must get into, and which are ones that I could submit to have answered after the fact. Perhaps the nurse could send me a note through the electronic medical record to answer questions 10 through 15 on my list. So I think you can overwhelm a visit if you show up with a list of questions that are, if they're even 30-second answers, might take an hour to answer all of them. That's sometimes counterproductive, in my opinion, to have that level of detail on a single visit. But it's fair to say, can I contact the healthcare team to get these answered electronically through the EMR? Or can we table this and go into the questions that we didn't get to at our next visit? I think both of those are appropriate. I think people that are not comfortable to kind of push back on the physician or the PA or the nurse, doing things in writing sometimes feels a little bit less confrontational for people. So I think that's important to have as a backup option.
And I imagine caregivers could be helpful in this regard as well.
Correct. Yeah, I think caregivers are a key part of that. And sometimes we go into a room and the patient says, yep, nope, don't have any questions. And then the caregiver's got a whole list of them. That's very appropriate. Caregivers have that responsibility and that role to play sometimes to be the key questioner.
Yeah. Are there resources to help patients and their loved ones weigh the risks and benefits of different treatment options?
There's lots of resources online, and I would make sure that you go to a trusted site. Sometimes things sound too good to be true because they're not true. But things like the Lymphoma Research Foundation or the LLS, the Lymphoma Leukemia Society, those are great sources for information. And sometimes they may link you to other sites. You could also ask your healthcare provider, does their institution have anything specific about this disease? Sometimes your healthcare provider might tell you, here's the right article if you want to go read the source, the clinical trial that was published that showed why this treatment's good. It may show you that paper, but online, careful how deep into the weeds you go, because sometimes you can find things that aren't correct. Get trusted sources.
Mm-hmm. Do you think patients should consider a second opinion consult with a specialist?
It sometimes is appropriate. Other times there's not a lot of time. If treatments need to right away, you don't want to get sicker because you're waiting for seeing somebody 2 states over and it takes 2 weeks to get there. Sometimes you want to start treatment and get the second opinion after you've kind of got the fire put out. But a second opinion usually gives more peace of mind than actually changing treatments. But if you've got that thought of, I'm not so sure this is what I'd like to do, or I'd like to get more information, a second opinion may be very appropriate.
Okay. So to close, Dr. Westin, what would you like to leave the audience with? Are you hopeful?
I'm very hopeful for the future for how we can beat DLBCL. We currently are curing the majority of our patients. We've got new weapons, which should look incredible and are continuing to help more and more people. But the main engine that we do help more people, the main engine that we make progress is clinical research through clinical trials. I think this is something that we don't want to rely on 1970s chemotherapy as we're getting into the 2030s and 2040s and 2070s. This is something that we should be able to improve upon and to move beyond. And the only way we do that is through clinical trials. So please do ask your doctor about what clinical trial might be right for you. And don't presume that a trial is something that's experimental or something that's not safe or not good for me. That's how your treatments that we're talking about today were originally discovered, was through clinical trials. So the future is bright. We're helping a lot of people, and we can do more and do better in the future.
Thank you so much for taking the time to join us today, Dr. Westin.
Thank you for having me.
And thank you to all of our partners. Please continue to send in your questions to question@powerfulpatients.org, and we'll work to get them answered on future programs. To learn more about DLBCL and to access tools to help you become a proactive patient, visit powerfulpatients.org. I'm Catherine Banwell. Thanks for being with us today.